little bit about how we approached COVID from the beginning and what we're doing now to manage it. And the purpose is to share what we're doing in case there's something that you find interesting or useful to you. You see my information on the first slide. I would encourage you to email me, call me, text me. Email is probably the best or easiest, but please reach out to me if you have a question. That's why I'm doing this, is to kind of share what we've done. So that's one thing I want to accomplish today. The second thing I want to accomplish is to introduce you to our region. We have a really interesting region in northwestern Alaska. I have a lot of photos of the region to show today. I want to get you all excited about maybe coming and visiting our region or working in our region or playing in our region sometime. So I do want to show that and kind of show off our region a little bit. So I'm going to accomplish both those things today. I will take a couple pauses for questions. I'm going to have Bev watch the chat box in case there's questions that come in the chat box. When I get done talking about our pandemic approach, I'm going to take a pause there. So, write your questions down. I will make space for them in the middle of the talk and then at the end of the talk as well. I'm also going to shut my video off. I just wanted to show you that I'm a real person here. I'm going to shut my video off during the program, and then at the end, I'll bring it back on. So this first slide, approach to endemic COVID in the Norton Sound Bering Straits region. Bering Straits Norton Sound is the water there, right? And the Bering Straits is our landmass. So we're the Norton Sound Bering Straits region. And was there a photo, Bev, of the hospital? Did we miss that? Anyway, I thought there was a photo of the hospital, a picture of the hospital in the slideshow, but maybe that's coming later. I want you to make you aware, I'm a family physician, and I was minding my own business 2.5 years ago as medical director when COVID hit. And like a lot of you, or all of you, and doctors and nurses across the nation, we had to sort of become experts at COVID. I'm not an expert, but we've learned a lot in our region. I may not be able to answer all your questions if you have questions, but we've gotten pretty good at things. So here are the demographics of our region. We're a region of 10,000 people across a very large area, 23,000 square miles. So that's roughly the size of West Virginia, or take a state like North Dakota or South Dakota, big rectangular states. We're about a third of North Dakota or a third of South Dakota. So it's a big geographic area. We're not the largest tribal health landmass in Alaska, but we're close to the largest. I mean, we're up there, but and that's what Western Alaska is all about. Big area, lots of villages that are available only by air. We have 3,500 residents that reside in the city of Nome. Nome is the end of the Iditarod dog sled race. Most people know about that. And we have about 6,500 people in our 15 villages. So 3,500 in Nome, 6,500 in our 15 villages. Those 15 villages are anywhere from 50 miles to 200 miles away from Nome itself. And the size of our villages are anywhere from about 75 people to 1,000 people in size. And I lost the slideshow, Bev. I'm not seeing the slideshow now. There it is. So 75% of the population are Inupiaq, Siberian Yupik, and Central Yupik Native Alaskans. Our largest population is our Inupiaq population, but on St. Lawrence Island, Savunga and Gamble are the villages. We have Siberian Yupik, and then we have Central Yupik and Stebbins and St. Michael's. The regional village communities are accessible by air only and range from 75 to 1,000 residents. And the distance is 50 miles to 200. We actually have one village that's on the road system for half the year, and that's Teller, which is pretty close to Nome. Go ahead to the next slide, Bev. So this is a map of our region. I want you to take a look at that. You'll see mainland Alaska on the right. You'll see the Russian mainland on the left. Look for Nome. It's in the center. Try to find that. That's our central hub. And then all of these are villages, our regional villages. There's 15 of them. You'll notice two areas are really close to Russia. Savunga and Gamble are out on St. Lawrence Island, and they're only 50 miles or so from the Russian coast. And then if you see up further north, Little Diomede, I'll show you pictures of that later, but Little Diomede is an island right on this side of the international date line. And that's actually from Wales to the Russian coast is about 55 miles. From Little Diomede to the Russian coast is closer to 20 or 30 miles. We can go to the next slide, Bev. Here are just some photos from the air of our regional villages. Brevig Mission and Teller are just across the bay from each other. You can see them from the air. Brevig Mission was a Lutheran missionary. Well, both Teller and Brevig were sort of Lutheran missionary outposts at one time. A lot of people have heard about Brevig and Teller. Teller is on the road system for us. Next slide. Here's Gamble and Savunga. They're on St. Lawrence Island, which is really close to the Russian mainland. These are Siberian Yupik Eskimo people from the Siberian coast. That's where their people are originally from. Gamble and Savunga, and their large villages, close to 1,000 each. Next slide. This is Little Diomede Island. The photograph on the left shows Little Diomede Island in the center, and then Big Diomede Island is to the left, further in the background. Big Diomede Island is Russian, and Little Diomede Island is USA. The international date line goes right between the two islands. They're 2.5 miles apart. So you're actually looking at tomorrow when you look at Big Diomede Island. So today we're here on Little Diomede Island, and we're looking across to, what day is the day? Tuesday? We're looking across to Wednesday across. So it's Today Island and Tomorrow Island. They're also called Today Island and Tomorrow Island, or Yesterday Island and Tomorrow Island. On the right is actually the village of Little Diomede. It's right down by the water. It's hard to see, but it's just that cluster of buildings right at the base of Little Diomede Island. And there's a helicopter pad right out there on the water. You can see that round circular pad. This is Diomede, Little Diomede Islands. It is by far the most remote outpost in the US. I mean, no question about it. It is super remote, helicopter only. In the winter, the water freezes. There can freeze between Little Diomede and Big Diomede Island. And if the ice is stable enough, they can shovel a runway, and you can actually land fixed wing aircraft right on the ice. Not always, but most winters they can do that. And there's around 75 people there, depending on the time of the year. Very, very, very remote. And did we get COVID there? Absolutely, we got COVID there, but we were able to deal with it, and I'll tell you about that. Go ahead to the next slide. These are some of our village clinics. All 15 of our villages have clinics, and they're Arctic designs. They all have running water and flush toilets, and they're very expensive to build and very difficult to build and very difficult to maintain. But we have health aides, local men and women who are trained to provide care, and they are our lifeline for those 6,500 individuals that reside in those 15 villages. We have some PAs and NPs that work in some of these village clinics as well. But they are kind of our lifeline. Our largest population is out in these remote villages. These villages are small. They have very crowded housing, very small housing. And as you can imagine, we had, sheer panic when COVID hit, because we had visions of our villages just burning up with COVID. Everybody's, in small houses, congested, poor ventilation. And so this was a big concern. Go on to the next. And this is the Koya Clinic on the left and the Savunga Clinic on the right. Again, you can kind of see these designs. It's built above ground because of the permafrost. They're both on sort of stilts, built above ground, but it's similar architecture for all these clinics. Next slide. Shishmaref on the left and Shaktuluk on the right. Shishmaref people have heard about because Shishmaref is on an island that's eroding, and there's been talk over the years about moving the clinic, moving the village to another village site. That's not happened. I'm not sure that it's going to happen in the future. It may, but Shishmaref people have heard about. That's their beautiful clinic on the left. Shaktuluk has a beautiful clinic on the right. Next slide. St. Michael's and Stebbins are central Yupik villages for us. If you know the YKHC area based in Bethel, the majority of their villages are central Yupik villages. These two villages are in our region, but they're central Yupik villages, right adjacent to the YKHC area. So St. Michael's on the left, Stebbins on the right. They are connected by a gravel road that's open in the summer by car and in the winter by snowmobile. Next slide. Diomede Island and Clinic on the left, and then the Elam Clinic on the right. Again, on Diomede on the left, you get the sense that these buildings are built right at the base of this rocky island. And to walk, you can just see behind the buildings, that's a steep incline just up to the top of the island. So it's really just a grouping of buildings right at the base of that island. The Elam Clinic is a beautiful clinic as well on the right, and they have a lot of their staff that posed for that photo. Next slide. So our initial pandemic approach was to delay the virus, to test aggressively for the virus, and then contain the virus wherever we found it. Our region was hit hard by the influenza pandemic of 1918. In fact, there are people in our region who remember stories from their parents and their grandparents about that flu epidemic. And we had villages that were wiped out from flu, completely decimated. We had other villages that posted guards on the outskirts and did not let anybody in or out of the village, and those villages survived. So our region has a mentality that was really logical, which is let's keep this virus out of our region as much as we can. We knew we couldn't keep it out forever, but our initial pandemic approach was to delay the virus getting to our area. That was our first job. It was to delay it while we could get testing equipment in place and get everything sort of ready. So number one was delay. We delayed the virus. Here's how we delayed the virus. We shut our airport down in Nome. We shut our Alaska Airlines flights down. We cut them down to like 2 a week. I mean, it was cut way back, and we shut down all travel to all the villages, completely eliminated, except for like essential groceries and water. I mean, it was crazy and it was dramatic, but it worked for us. It delayed the virus getting into our region. So that's A. On B, working with the city of Nome, we put mandatory testing in place at the airport in Nome. Anyone, eventually, once we allowed people back in, anybody coming into Nome was required to get a test, but mandatory testing. And C, we had mandatory quarantine of everybody coming into Nome or into the regional villages. So if you were coming into the region, first of all, you couldn't get here for a long time, for weeks, because we cut down all travel. But then we got testing equipment in place. And then when we allowed you to come in, you had to test, and you had to quarantine, and you had to test again. So we really, delayed the virus by having that aggressive plan in place. Next slide. Are we, I see in the chat, are we okay, Adriana, to continue?
One second. Dr. Peterson, Ms. Tran just needs to stop share and share again real quickly because she sent those files and it interrupted her Zoom. So she's gonna stop share and she's gonna share again and put it in presentation mode, and you should be good to go. That's
okay, I'll wait for your cue.
Yes, sir. Thank you. Okay, there we go. Presentation mode.
Did everybody not see the slides?
Now display settings. Now go to display settings when you put it in presentation. Okay.
Sorry, I'm trying to figure this out.
Go to
Okay, display settings.
and then you want to duplicate.
Okay, how does that look?
That is correct. Thank you. And then I think he was on slide 7.
Okay, just give me 1 second to get there.
Sure, take your time.
Teamwork make the dream work.
Yes.
One more. He was right there. Thank you so much. And thank you for your patience, Dr. Peterson. And
Yeah,
thank
no
you
problem.
all of the attendees for your patience. We're ready to go.
Okay, so we delayed and then we tested. Let's talk about testing. We worked hard and rapidly with the assistance of ANTHC, which is our consortium lead in Anchorage, and ANMC, the hospital, and ANTHC, to acquire Abbott ID Now analyzers in Nome, in our hospital in Nome. So initially we got ID Now analyzers in Nome, and then we were eventually able to get one analyzer for each of our 15 villages. So we worked really hard and really fast to get analyzers. And we got about 15 analyzers in Nome, in our lab in Nome, running not around the clock, but pretty close to it. And then we put one in each of our villages. Even out in Diomede, the most remote place right next to Russia, we had an Abbott ID Now analyzer because we had to, you got to be able to test to know who's got it. So, and we educated all of our health aides, trained them on how to use the analyzers. And in Nome, we had some off-site testing locations in town and out at the airport as well. Next slide. So this is one testing site. This is a tent right in front of our hospital. And that's actually where we did all our testing of all of our employees and any patients that were outpatients that needed testing. We didn't want patients coming into the hospital to be tested. So we had this one offsite location right in the parking lot of the hospital. We had one in the parking lot of the airport. And then we had eventually another location in town, not far from the hospital. So this is just pictures of our Arctic tent for the hospital and people waiting in line to get tested. Next slide. So we delayed the virus, then we got testing in place to test really aggressively, and we did aggressive testing. I want to talk about that. We put requirements of testing for all of our employees I think it was initially every 2 weeks, either every week or every 2 weeks. We tested everybody in the corporations. That's a lot of people. 800, something like that, every 2 weeks. And we recommended the entire region test every 2 weeks. Not everybody did, but a lot of people did. And we did a huge amount of testing, just a large amount of testing. Contain, number 3 was right here, contain. So we worked with every regional community to identify appropriate isolation quarantine housing in Nome and in all of our 15 villages. Our panic was, if we get cases in our regional villages, there's no place to isolate. There just isn't. But we had to work to find isolation housing. And we worked with the tribal governments of each village, city, IRA, and the tribal governments of each village to try to identify housing in each village. And most villages were able to come up with some housing where we could put initial people who tested positive. That was a real key element for us. So all initial positive patients were placed into isolation housing. All initial close contacts were placed into quarantine housing. Eventually, as the numbers grew, placing positives and close contacts into separate housing was just not possible. But by the time that we gave that up, people were already immunized. Omicron was here, which caused less severe disease. So we were sitting pretty good. By the time we could no longer isolate people in separate housing in our villages, we were in a much better position. Next slide. We developed, this is a real key slide for us. We developed our own COVID response team of physicians and NPs and PAs who covered a specific call line, 24/7. We had a call line, a COVID call line, right? All calls went into that line. These were the experts. They're just people from our staff that developed additional expertise. And they responded to every positive result that came through of all this testing we were doing. Any positive result would go to this line. This team would deal with it. They would educate the patient, do all the contact tracing, get everybody into isolation that needed to be or in a quarantine. And then they worked with our housing team, quote unquote housing team. We have a housing team who coordinated all this housing in Nome and in the villages to get people into isolation housing and quarantine housing. So those were really two key elements, and those remain for us as we deal with the endemic COVID. The second paragraph, we developed a housing team of staff who coordinated all the isolation and quarantine housing in Nome in the region, along with the distribution of groceries and water to these households. We found that people were much more willing to isolate and quarantine when we were shipping them boxes of food and water. They had a tendency to want to go to the store to buy things and get things when they really needed to stay put. So right away, early on, we developed a system where we got groceries and water. Remember, we're having to buy this stuff in Nome and ship it out to the villages. I mean, they have grocery stores, but we might have 20 families in one village that all need boxes of groceries and water. And the grocery store in Savunga, for example, would not have the capacity to deal with that. So we were buying this stuff in Nome or even in Anchorage, having shipped out to Nome and then shipped from Nome out to the villages. And it just was free of charge. We didn't charge anybody for any of that throughout our whole region. And that really helped our region participate. Nobody wants to isolate. Nobody wants to quarantine, but it's a lot easier to do it when you know you've got, goods coming and you're going to get taken care of. Next slide. Employee testing. We had mandatory testing of all employees, and that's about 800 people. And we did that testing every 2 weeks. By the time the virus reached our region, we had a good, fairly robust system of testing and contain in place. Next slide. This is the heavy testing, and you know, you need to have a positivity rate that's really low, like under 5%. That indicates that you're testing enough to catch all the COVID in your region. Over the course of the pandemic, through October of 21, we did roughly 125,000 tests in our region of just 10,000 people. We had a positivity rate that was just 1%, meaning we tested a ton. We probably tested 2 or 3 times more than any other region in the state. And we know that because the state data was coming out every week and we were looking and comparing. We were nuts about testing, but it really, I believe saved us. This low positivity rate indicates we were doing enough testing to identify essentially every case in our region, or close to every case, to get it appropriately isolated, to minimize disease spread, and it worked well for us. To date, we've only had 46 hospitalizations. And if you take that over like almost 2.5 years now, that's about 1.5 admissions per month. So we've really had, you know, and of course they were clustered during the bad times of the pandemic, but our hospitalizations per capita were really very low, and we've only had 6 total deaths in our region of 10,000 people, which is quite good. And we're thankful for that. We feel that our heavy testing program helped us identify the vast majority of cases early to get them appropriately isolated, treated, and close contacts quarantined. Next slide. Vaccinations. So we wanted to delay, test, and contain until that vaccination could come, and we couldn't get the vaccination soon enough. When the vaccine was finally ready in December of 2020, we were top of the list. Alaska was top of the list. Rural Alaska, we were treated well. I mean, we were on the top of the list. Our state and ANTHC and ANMC and the state of Alaska really advocated for rural Alaska, because everybody's fear was that things would catch on fire, and they did in Western Alaska. Our region did better than others, but there was catastrophe in a lot of the states. So we were on the top of the list. We were in the very first days of the vaccine, we got vaccine. We had mandatory employee vaccination. We're the first one that I'm aware of in the state to do mandatory employee vaccinations. And there was some pushback on that, but not much. And that saved us. We've sent vaccine teams all over our region, sent teams to the village clinics to get vaccination started. We trained our health aides to give the Moderna vaccine, and they've done an outstanding job of protecting the region with Moderna. In Nome, we set up offsite vaccination centers in town and at the airport. So you come in on Alaska Airlines to Nome, you were offered a vaccine, not a requirement, but you got to walk through the tent, and you gotta hear our pitch as you go through. And that's how it was when the vaccine came. We had good early success with getting our region vaccinated, especially the over 50 population. By the time Omicron hit, you know, there was that lull, things were looking better, and then, oh gosh, Omicron. But Omicron was more infectious, but it wasn't causing as much hospitalization or death or severe disease. By the time Omicron hit, we had 85% of our eligible population, 12 and up, was fully vaccinated. And this definitely contributed to the low morbidity and mortality in our region. So we were just waiting for that vaccine to come, and it finally came, and we really hit it hard getting people vaccinated. Next slide, please. Additional efforts. We had a daily call-in, a tribal leader call-in every Wednesday at 11 a.m. Our CEO is on that. I'm on that. Our PR people are on that. A number of people from Norton Sound are on that. Anybody in the region can call in. We did daily calls, and then it went Monday through Thursday for like 2 years. Now we're doing it just once a week. But Monday through Thursday at 11 a.m., any resident could call in. I would give an update on where the cases were, and people could ask any questions. We did a ton of education. The calls would initially go 1, 2, 3 hours, gradually 1 hour, and now, you know, we've cut way back, obviously. Those were really helpful. Communication was key for our region. It's a huge region. Communication was key. We had weekly managers meetings to discuss strategies, and we had regular village tribal calls to discuss new village cases. Whenever we had a new village case, positive case, we would have a tribal call. The leadership for Norton Sound would call the tri-council in that village and just update them on every positive. Anytime there was like a new little outbreak, even if it was just 1 or 2 cases, we'd have a call. The communication was that important. It was exhausting, but it really helped keep people calm and doing the right thing. Next slide, please. Additional efforts, we developed a cough and cold clinic in Nome where all of our outpatients with cough and cold symptoms went. Like a lot of you all did the same thing. We redesigned our inpatient unit to accommodate COVID patients. Telemedicine was a huge factor for us, as I'm sure it was for all of you. For our region, extremely helpful. We could continue our psychiatry care, for example, to all of our 15 villages through telemedicine. In fact, we could call right to patients' homes. For general medical care, we could do telemedicine, so that was key. Next slide. Additional efforts, we had contests and raffles to encourage vaccination. So we did a lot of creative stuff. We have a lot of creative people at our corporation. We had raffles and prizes and basketball tournaments and things like that. Our tribal leaders designed programs in their individual village, and then we supported that. Norton Sound supported that. You know, would send vaccinators out there to maybe their gymnasium when they had a basketball tournament or a training camp for kids, and then encourage the kids to get vaccinated at the same time. So a lot of collaboration required, and a lot of collaboration with the city of Nome as well. We really worked well with them to make things happen in Nome as well. Next slide. So that was our pandemic approach. And now I wanted to talk a little bit about the endemic approach. What are we doing now that the pandemic is over and now we're sort of living with COVID? I was going to pause here. If somebody has a pressing question in regards to our pandemic approach, feel free to ask it now. You can ask it at the end as well. We'll have a pause there too. But if anybody, I promised I would take a pause here. So I'll just pause for a moment in case anybody has a question. And feel free to type in the chat as well. I'm going to talk about our endemic approach. Here's what's disappeared. We no longer have travel restrictions, right? The virus is here. It's in our region. It's not going away. And restricting travel is no longer going to be helpful. We no longer have mandatory testing of all the corporation staff. That ended quite a while back. Now we just encourage testing if you're symptomatic. Testing of regional residents, we encourage them to test as much as they want, but we remind them the importance of testing when they do have COVID symptoms. So really important to test, but we don't do mandatory testing. We've reduced our testing locations in Nome. We no longer test at the airport. We no longer test downtown. We test conveniently in a walk-in clinic in our hospital. We've reduced our vaccination locations as well. We don't vaccinate at the airport any longer. We don't vaccinate downtown, but we have convenient vaccination locations in our clinic in Nome and in each of the individual village clinics as well. Next slide. I'm going to read a question here that came up. Did you say how much travel occurs normally between your region and the adjacent healthcare jurisdictions? So I think the question is between Nome and the villages, normally how much travel happens. Is that the question?
Her question was, how did communities react to activities and attempts to prevent the spread of COVID?
Okay, and I think there was a question right before that. Let me answer
And
that.
you had another one where it was like, did you say how much travel occurs normally between your region and the adjacent healthcare jurisdictions?
Okay, so Nome is our central hub. Our 15 villages surround us. We have, normally without COVID, we would have a doctor or a dentist or an eye doctor in our village clinics all the time. So we travel from Nome to the villages all the time, every day for medical travel. Patients are coming between Nome and their regional village every day. So tons of travel. That was really shut down during COVID. We really limited travel. Now, if the question was, is there much travel between our Norton Sound region and an adjacent region like YKHC in Bethel is kind of an adjacent region to us. Kotzebue, Manilik Corporation, that's just to the north of us. There is some travel between villages that are in the Manilik area, or the YKHC area in our area. There is travel between those villages that we restricted. But yeah, there were cases where maybe there was an outbreak in a Manilik village or a YKHC village that traveled over to one of our villages and caused, infections in our village or vice versa. So that does happen occasionally. How did communities react to activities and attempts to prevent the spread? I will tell you, they reacted like the rest of the country, right? I think those people over 50 understood, and they were excited about getting the vaccine and they wanted to be protected. Younger people, not so much. They weren't as excited. Our vaccination rate for those over 50 is outstanding. It's like 95% or even higher. But you get under 40, that 20 to 40, it's lower. Our average still comes out at 85%, but it wasn't as good in the younger population. And when you get to children and younger, it's lower yet, just like the rest of the country. So we got the vaccination to happen where it really needed to, that high risk group, but younger people not so much. And most communities reacted positively to events like, let's have a basketball tournament, let's have a raffle, let's have a Eskimo dance and vaccination. Most of them responded positively to that, but just like the rest of the country, there were pockets of people that were convinced this was a hoax and this was made up. And that is difficult to deal with from 200 miles or 100 miles by telephone. That's difficult to deal with. And you're trying to support the health aides that are there at the same time. And then, okay. Okay, one of the main concerns on our reservations here in Montana is multiple families living in the same home. Was it an issue in Nome? Yeah, absolutely. I mean, we have multiple families living. We might have a small 2-bedroom house with 11 people living in it. So that's why we couldn't just hang out and wait for this virus to come. It would have wiped villages out. That's why we worked aggressively to get testing in every village, to get isolation and quarantine housing, because it really worked for us when we did finally have some outbreaks in villages. We were able to limit the number of cases in those villages. But absolutely correct. Small houses with lots of people in them, and just a bad combination with COVID. Again, because we got people vaccinated, but by the time Omicron came, right, you just threw in the towel, because Omicron just whipped through everybody. I mean, in 2 years, we had X number of COVID cases in our region. when Omicron hit, in 2 months, we had the same number of cases. But the difference is that for those first 2 years, those first initial variants were really dangerous. And, you know, people were dying, getting hospitalized and dying from those variants across the country. Thankfully, we didn't have a ton, but when Omicron hit, it wasn't as deadly of a virus. It wasn't as virulent, but boy, was it infectious. And in 2 months, we had just as many cases as we had in the first 2 years. So yes, we had that same struggle, but by then we had our elders all vaccinated, which is good. Okay, keep sending in the questions as you have them. I'll keep reading. So what remains of in our endemic plan, what remains from our pandemic plan? Here's what remains. We still have a COVID response team. Right now, we have 2 physicians. It used to be multiple physicians. We have 2 physicians that are on 24/7. They just alternate weeks. And they're actually on from like 8 a.m. until 5 or 6 p.m. And they respond to any positive result. And they work with the health aides and our PAs and NPs in the villages to deal with any cases that come along. But we've been able to shrink our response team. Okay, we still have a housing team. We still got to coordinate housing. We have a cruise liner that's going to land with 500 people on Saturday. And this housing team already has plans in place because there's going to be some COVID. There's a few cases. So we have that team in place and they're going to take care of that. So having a housing team, I think, is really critical. We still have testing available in every community and we have antiviral treatment. Our COVID response team initially did all the treatment. They became experts and they did all the treatment. Now all of our physicians and our advanced practice practitioners are all educated and they prescribe. So we have Paxlovid, Molnupiravir, Remdesivir, Bebtelovimab, and Evusheld. We have all of that available, and our COVID response team and all of our physicians prescribe that. We currently, this is when I wrote this right last week, it's changed now, but we're averaging about 4 to 6 active cases for our region up till recently. So we were only having 0 to 2 or 3 cases a day. And we continue to test about 30 to 70 patients daily. Our positivity rate is less than 3%. That's where we were up until about a week ago. And then we have like 20 active cases right now in our region, about 20, 24. But then I noticed our testing went up to like 80 or 90 a day. So we have a real good system in place because it's our COVID response team. As soon as there are more cases, our response team is ordering more testing, it's getting all the close contacts to test. So it's kind of on autopilot now, which is good, but you got to have that. You got to have a response team. You got to have a housing team, I think, to make it work. Next slide. So here's a question and answer period. If there are other questions that you have. I'm going to read one question here. In Montana, Arizona, several tribal communities resorted back to traditional herbs and songs to combat COVID-19. Was traditional Alaska medicines used before the COVID-19 vaccine came along? There wasn't anything specific that our region used to fight COVID. But there were some symptomatic treatments. You know, our region will make tea from certain greens. And so there was kind of what our region uses for symptomatic treatment, you know, symptoms of stuffy nose, congestion. Absolutely, they continue to use that. But we didn't have any native remedies that were used sort of in place of the antivirals. So yes, traditional medicines and herbs were used. our region is pretty accepting of Western medicine and treatments. And so we didn't get a lot of pushback on that, to answer that question. Other questions? That's a photo of our hospital in the background. It's a big hospital. It was built in 2013, and it's really large for our region. And I worked as a staff physician in our old hospital, and when you look at the old hospital as compared to the new hospital, it was so tiny. But now we're a bigger sort of corporate entity. That's a gold mining dredge that's sitting right in the foreground there. And, that's from a bygone era of probably like from the 50s. I think that's a Swanson's dredge, Bev would know. And that's probably from the 50s. And that was digging, that floated on the water there. And then that would dig the earth underneath at the bottom of the water and process that dirt and gravel, and it uses the water to sift over that dirt and gravel and wash everything away, so you're left with just the gold nuggets. Just like a gold pan, you scoop some gravel in the gold pan, you use water to sift off the dirt and the gravel, and the heavy gold remains in the pan. Well, this is like a huge gold pan, right? But it's a big dredge, and it's got the big buckets on that arm that sticks out front. It's got big metal buckets that pick up earth and push it through the machine. And inside the hub of the machine, there's water spraying over that dirt and gravel, and it leaves the gold behind. There's still lots of active gold mining going on in our region. There is, people will mine right off the coast. They'll go out, several 100 yards in a little raft, and they'll dive down in wetsuits, and they'll suction up the bottom of the ocean, and they'll suction that dirt and gravel up and then wash that off to pull up the gold that's there. So, and there's mining back in the mountains. You can see the mountains behind the hospital. The mountains get bigger and bigger the further north you go. And as you get back to the mountains, there are mining camps back then. So still a lot of active gold mining going on in our region. Last slide, Bev. I think there's one more. So again, that's just got my info. If you have other questions and things, let me know. But that's kind of the end of what I have. And again, if you want to reach out to me on anything that we're doing in our region, happy to have a conversation with you about it. I see a couple more questions. Do you have lessons learned on how to increase vaccinations in your regions with various groups that were vaccine hesitant? Specifically, did you change how you framed reasons to get vaccinated? This has been an ongoing struggle for the state of Alaska, is how do you get those regions vaccinated that were hesitant? I will tell you that our best method for getting people vaccinated was to really educate people about the severity of the disease, about the importance of getting the vaccine. That was our huge push, just the basic push. And we got a large number of people vaccinated. I think just pounding away at that, having raffles, having events, and keep presenting that over and over, that's what was effective for us. And we never really came up with anything. I mean, we sort of paid people to get vaccinated in a way. I mean, we had gift cards and other things. So that was effective for us. It really was. But we didn't ever discover, something dramatic that got the 20 to 30-year-olds vaccinated. We had a van for a while that drove around town and would park in the areas where young people would hang out, and it was somewhat effective. but I wouldn't say it was overly effective. So, I wish I could say that we did. I don't have anything to share other than just to kind of push the importance. We're going to have a little trouble, I think, getting all of our school-age children vaccinated. We're still pushing that, but now that COVID's kind of dying down in some ways, or it's becoming less important, it's even harder to get people vaccinated. So it's a bit of a struggle. Yes.
% compliance rate with your employees in your health system, and if you did not, how you are now handling testing of those exempted employees.
Yeah, one more time. Could you ask that one more time? There's a little bit of a reverb there.
Okay, I was just wondering if you had 100% compliance rate with that primary series of COVID vaccine with your health system employees, and if you did not have 100% compliance, what are you doing about testing exempted employees now that we're more endemic?
So we required all employees to become vaccinated. And the reason we did that is we knew that it was important for our future. So, and we had already had mandatory influenza vaccine, so we already knew kind of how to do that. So we made it mandatory, but then we gave people time to make that decision, right? I mean, I think we gave people like 6 or 8 weeks to really make that decision. There was pushback from a small vocal set of the population, but you know what? So if there's 20 people that were in, we had 800 employees. We have 800 employees. So 750 of them, 775 of them, no problem. They just all got it because they knew they had to. But the 25 or so that were hesitant, when we worked with them and we explained, we educated, I do talks with them, half of those people got vaccinated. It wound up only being a small, probably one handful of people, maybe 4 or 5 that decided, no, I'm gonna move on. So really out of 800, it wound up just being a tiny number of people that didn't, and they chose to move on. So we absolutely have everybody, and then everybody new coming into the corporation had to be vaccinated. That's pretty easy to do. If you don't want to get vaccinated, you can't work here. Now, the reason that that's been so helpful to us is because if you're vaccinated and you're a close contact, you don't have to quarantine anymore, right? For the CDC. So, whereas we had to quarantine our people before, if they come into close contact, it's hard to run a hospital when people are having to quarantine because they're close contacts. So we knew we had to get everybody vaccinated. And so we have everybody vaccinated. So if they're close contacts, we still want them to test in a few days right after contact, but they can continue at work. And I would strongly encourage every place to require vaccination. It really is a small number of people that will resist it. Are mask mandates worth it? Yeah, they were effective, very effective for us. They really were. And for our region, it was really helpful in a remote village, 200 miles from Nome, where maybe people were not living COVID day to day. When they saw people in masks, oh yeah, they remembered there's COVID in their village. People have masks on. They got to be careful. It's a reminder. But yeah, we found masks very, very helpful. We had mandatory masking in the city of Nome, and we could tell that it was effective. It's no longer mandatory. It's mandatory certainly in our hospital, in all of our clinics, but not in the communities any longer. I mean, it may come back as we have more cases, perhaps, but yes, I found them worth it. Yep. Other questions?
So Dr. Peterson, did you see the question in the chat about the traditional herbs?
Yeah, and I did respond to that. We did have traditional, we have traditional medicine that's used in our region for symptoms, and that certainly continued, but there was nothing new that developed for COVID specifically.
Do we have any additional questions from the audience? So I have a question for you. As we see an increase in case and hospitalization rates, should we still treat COVID as an endemic plan since we have like the new strands that are coming up, or how should most healthcare professionals move forward?
Well, the CDC right now recommends when your case rate gets to a certain level, you gotta start doing more things like consider masking again. So whether we're in a pandemic or endemic, the way I describe it for our region is, it's here to stay. It's going to fluctuate. We're going to have low case counts on some weeks. We're going to have higher case counts on other weeks. And I think we have to adjust what we do based on those case counts. So when things are really low, I don't think there's any need for masking, but there's definitely, everybody's got to test. If you're symptomatic, you got to test. If you're a close contact and you're not vaccinated, you got to quarantine and you got to test. So you got to have a COVID response team that's doing all of that. So all of that has to continue. And then if your case rates go up, now you got to talk about masking again in the community. Residents got to mask again, and then they got to be careful again. So if we get like a large number of cases in any of our villages, we'll have tribal leader calls again. We'll go back to masking. We'll go back to, so we're going to slide between our pandemic approach and our endemic approach. We'll kind of slide back and forth. So you have to tailor it to where your case counts are at. At least that's what we're going to do for now.
Okay, so just for myself, and maybe this will help other people. So at what point, because you just talked about that, I just want clarity. So at what point do we reduce focus on case counts and use severe cases to measure COVID impact within tribal communities so that we can reinforce like masking in like public spaces?
Yeah, so I think your question is, if we have more cases, but hospitalizations don't go up, do we need to be as concerned? I think that's what you're asking, correct? If hospitalization rates are not going up?
Correct.
Yeah, I mean, I would agree with that. If case counts go up, but nobody's being hospitalized and nobody's dying from the virus, I don't think we have to be as aggressive about our mitigating efforts. But to be honest, for our region, because we're always worried about villages getting a lot of cases, for our region, when we see case counts go up right now, we're going to get aggressive and we're going to test, isolate, quarantine people. We're just going to be aggressive. And you know what? 3 months from now, if we see that hospitalizations and deaths have not gone up from this, we'll gradually be less concerned and we'll gradually do less. So I think it takes time to know what to do with this virus, right? Cases are going up. We haven't seen a lot of additional hospitalizations. There's been some, but we're not hearing about a lot of deaths. So I think it just takes time. It's going to take another 3 months to figure out if we're going to have more hospitalizations and deaths. What we're going to do for our region is assume that there's going to be more hospitalizations and deaths as case count goes up. So we're going to be pretty aggressive. Okay. But then over the course of 3 months, if it's like, hey, across the US, case counts are up 30%, but hospitalizations are really and deaths are really not up, then it becomes more like influenza where we get a little bit more relaxed about it. So I think we'll get more relaxed over time, but we're not going to get too relaxed for now, if that makes sense.
Correct. And so Ms. Jane Lee from CDC has included some community resources in the chat box. Please be sure to check it out. There are links to the COVID-19 community levels mapping, as well as their science and community levels. Ms. Jane, I don't know if you want to come off mute and just talk about those resources. a little bit more that supports a lot of the information that Dr. Peterson is sharing and has shared?
Sure. Can you hear me?
Yes, we can.
Oh, wonderful. Dr. Peterson, what a wonderful presentation. Thank you. Thank you. Just really quickly, the COVID community levels. The first one is a little bit why tribal nations may want to consider using these COVID community levels. And then the second one is how the COVID community, more about the COVID community levels. What three factors they're looking at. So it's hospitalization first over case numbers and some other things. And they kind of explain how to calculate it. So in theory, tribal nations and can kind of figure out for their own if they don't want to use the COVID community level guidance numbers and preference the case counts above hospitalization rates. But if they'd like to, use it, these two links are helpful.
Yeah, and I would agree with that. The CDC education material is really helpful about what to do for your community based on hospitalization numbers and so on. I think that's where you want to go to decide what your community needs to do right now with the number of cases and hospitalizations that you have. That's extremely helpful.
And so, Dr. Peterson, I have a personal question. First of all, I want to commend you and your team of all of your efforts to mitigate COVID. During your presentation, you talked about your COVID response team within your healthcare facility. Curiosity question, in terms of that COVID response team and that housing team, for those that work at you all's, the Tribal Communities Command Center, were they brought in at any point during the conversation? Because I know some tribal communities, their COVID response team was comprised of different sectors. It wasn't necessarily just a healthcare. They pulled in people from like the fire department and the schools. Did you all do that also in terms of when you all were isolating people?
Yeah, so here's what we did. Initially, we have a public health office in town, and it started with 3 public health nurses when COVID hit. They did, the state did contact tracing for us initially, but as case numbers went up, they just couldn't take care of things. They just across the state. So we had to have our own COVID response team do our own contact tracing. So, and we used our own physicians. We had some additional hires that we brought on to help with COVID. So we had new hires to our corporation, but they were employees, and we utilized them. I was one of them with the rest of that team as part of the COVID response team. And the community of Nome, the city of Nome, and the tribal governments and the IRA and the cities of each of our city governments of each of our villages deferred to Norton Sound for the guidance on the healthcare with everything COVID. So they deferred to us on that. But I will say this, that Norton Sound and the city of Nome met on a regular basis, a weekly basis, with our own emergency response. So we met weekly to discuss things of a city and Norton Sound nature together. So we had Norton Sound response team that handled really the medical COVID response for our whole region. We kind of ran that show, but we did it collaboratively. And then the city of Nome itself, like the airport testing, and that's a city response, but we worked collaboratively. So the city met with Norton Sound on a regular basis to respond to that. So I don't know if I'm answering your question with that answer or not.
Oh, yes, sir, you did. I was looking for info into who your other partners were. I was just being nosy. That was.
Yeah, so the city of Nome, definitely, we worked really well together on all this, and we continue to. And then each tri-council in every village we worked with as well.
Okay.
Yeah, so a lot of collaboration.
So do we have